Good evening, good afternoon, and good morning, everyone. Thank you for joining this webinar, and a very warm welcome to everyone. My name is Dickens Somedo Ochuka, and I work for PATH, and I'm based out of the Kenya Country Program Office. And I lead the Early Childhood Development Project in Kenya, and I will be moderating this webinar today together with my colleagues Sheila Manji and Svetlana Drivdal. All are my colleagues, and feel most welcome. Today, we will be talking about the work that we've been doing on scaling up early childhood development at scale through primary healthcare. And specifically, we will be sharing models, materials that we've developed for programming over the years. And also, we will be able to share some of the lessons that we've learned over the period that we've been implementing our early childhood development interventions across three countries, that is Kenya, Mozambique, and Ethiopia. And this work spans for close to over a decade now when we started this implementation. So this webinar will bring experts from the World Health Organization, the Ministry of Health in Kenya, the Ministry of Health from Mozambique, and the African Center for Early Childhood Development in Ethiopia, and PATH colleagues, just to discuss the evolution of how this work has evolved and share some of the key successes and lessons that we've learned over the period. So today we will hear from a very great list of panelists, and in the house today we have panelists from Kenya, and we have two of them. We have Janet Karimi, who is the head of the Division of Newborn and Child Health at the National Ministry of Health. And we have Kennedy Orwenjo, who is the Director for Public Health in one of the devolved units, the subnational level, that is called Siaya County in Kenya. We also have our MOH representative from Mozambique, Marina Karaginis, who is the focal point person for early childhood development in Mozambique. And we also have Meseret Zelalem, who is the Deputy Chief Executive Officer at the African Center for Early Childhood Development in Ethiopia. So a very warm welcome to our panelists and to everyone who has joined the call. And please feel free, if you have any question, please feel free to submit them on the Q&A channel on this call, and you can also share your ideas and feedback in the chat. And we will make sure to look at them and respond, and ensure as you send your ideas or feedback, just send it to everyone so that all in the call can be able to see. So at this particular moment, I just want to take the mic and hand over to Devjit, who is going to run us over on the first presentation. But just to mention, our agenda today, we look at laying a foundation of the ECD work at PATH, and then that will be followed by a panel discussion from the colleagues that I've just mentioned. And then we will have opportunity to also share the knowledge hub that PATH has developed based on the lessons and learnings from our programming. And then finally, we can have Q&A from our very able audience. So thank you, and over to you, David.
Thank you, Dickens. It is such a pleasure and an honor to talk about our early childhood development work. And I note that there are people joining us from all over the world, including people from South America and South Asia, aside from the countries that Dickens mentioned. So welcome, everyone. A good morning, good afternoon, good evening, because I see some folks from South Asia as well, to you. So first, I will just start us off by talking a little bit more about the evolution of our early childhood development work. Next slide. Next slide. So why early childhood development as part of primary health care? The Lancet series, the Foundational Lancet series of 2016, talks about 43% of all children under 5 not at risk of not reaching their developmental potential, and nearly 2/3 of children in sub-Saharan Africa. But it is in the early years that the brain is most sensitive to stimulation and where developmental delays can be avoided as well as reversed. And primary healthcare in the early years is the best vehicle for reaching young children and their caregivers. Next slide. And none of us are a stranger to the Nurturing Care Framework, which in 2018 was launched, and for the first time says that for a child to reach their full potential in life, they don't only need health and nutrition and protection, but also responsive caregiving and opportunities for early learning, and that primary health care has to expand its mandate to include all of these domains. Next slide. And the next slide. So our value proposition, essentially our model, it's not as one of the stalwarts in our field, the great Professor Linda Richter said, it's not just about training and forgetting. It's not about capacity building only. We look at the whole ecosystem, whether it be strengthening the enabling environment, the enabling policy environment, ensuring that service providers have the right tools, that service providers are trained, that the data that they're collecting incorporates early childhood development, and that we're also being intentional about bringing in partners, both obviously government partners, but non-governmental partners, to ensure that it's more than capacity building and that we're strengthening the whole ecosystem within which early childhood development is promoted through primary health care. Next slide. And this is just a quick snapshot of where we are currently working and where we have worked in the past, but also countries where we have done landscaping, offered technical assistance. As you'll notice, the bulk of our work has been in Sub-Saharan Africa, Eastern, Southern, a little bit of West Africa, but also in Europe and Asia as well. And there's a list of our donors for whom we're very grateful for their support for scaling up this innovative work. Next slide. And the next slide. So the first chapter of the story, and I know I'll be probably going through these very fast, and obviously the recording will be shared, the slides will be shared, and you're very happy, we would be very happy to receive feedback from you later on about these materials, about our approaches. And as my colleague, Dr. Svetlana Drivdal will tell you, there is a fantastic online knowledge hub where a lot of these materials are available. So the story goes back to over a decade ago, to 2012, 2014, where we realized that primary health care was missing a key component, namely promoting early childhood development. And we started off by adapting the basic Care for Child Development package, including content, ECD content on pregnancy, developmental milestones. The basic package did not include milestones. It just included responsive caregiving and early learning activities, but also made the content more responsive to mores of adult learning. However, we realized that there was some issues with integration, that service providers were not integrating, but sort of seeing this as a separate module, which is why we moved to the next phase. Next slide, please. Where we co-created sets of comprehensive visual counseling cards where we separated out the content across all the touch points in that continuum of care: antenatal care, maternity, postnatal care, the first 6 months, 6 to 12 months, 12 to 18 months, you name it. And at each stage, there were detailed messages, detailed counseling messages on how service providers could promote responsive caregiving and early learning. And this was a set of, I think, 32 counseling cards. I've just screenshotted 2 of them. But we also realized that it was not just about the technical content, but it was critical to emphasize interpersonal counseling skills so that service providers were not just sharing, but they're actually actively soliciting questions from caregivers, that there was actual counseling and not a one-way transmission of information. Next slide. So the counseling cards focused on promoting 3 major sets of activities. The first was developmental monitoring and counseling within the health facility. And as you can see, there's a service provider who's using that nice thick stash of counseling cards to counsel a caregiver. Next slide. Similar activities happening at the level of household visits by community health workers. Next slide. and also play sessions in health facility waiting rooms, which are generally not very child-friendly, and where caregivers spend a lot of time waiting to receive services, and which can be used to promote early childhood development by counseling caregivers, demonstrating how they can play and communicate with their children. Next slide. However, we realized that having a 30-page set of counseling cards, the cards were brilliant, everyone loved them, they're colorful, they were comprehensive, but scaling them up within the constraints of a low-resource health system was just not feasible. And so through a process of co-creation, we condensed the content into two posters, one poster showing developmental milestones, another poster showing ways in which caregivers could play and communicate with their children. And this was the set of materials that was used to train every community health worker and health facility service provider in 3 geographies, Siaya County in Kenya, Maputo Province in Mozambique, and Addis Ababa in Ethiopia, in addition to other smaller geographies. Next slide. In addition, we also worked with the government in Ethiopia and the Regional Health Bureau in Amhara in Ethiopia to look at ways in which this work could be integrated into post-conflict primary healthcare reconstruction efforts, also including aspects of maternal depression support, which I will come to in just a few minutes. And this work was associated with a significant reduction in maternal depression symptoms, suggesting that early childhood development and caregiver mental health support should be an integral component of primary healthcare reconstruction, something that is very germane, I think, especially given all that is happening in the world right now, natural disasters, conflicts, and whatnot. Next slide. So as we moved from this phase, as we started moving and maturing our model in this phase, we realized it was critical to also strengthen the enabling environment at national and subnational levels, so that this work would remain in the DNA, so as to speak, of the primary healthcare system, which included advocating for integration of relevant content into budgets, guidelines, policies, tools, ECD indicators, so that health service providers would be actually logging data as part of their routine services, as well as working with partners such as KMED in Kenya to go beyond the technocrats, so as to say, but also cultivate executive leadership. So governors or other such leaders at subnational level, first spouses, but also bring in other sectors to ensure that this work would continue to remain relevant. Next slide. But as we moved from this phase, we realized that certain groups required additional support, and that who would not necessarily be covered by a universal model. And these included adolescent girls and young women who were mothers or who were pregnant, who were more likely to be depressed and not access primary health care, as well as children, very young children with disabilities, since a lot of disability services tend to focus on older children. And when children are in these services, they do not necessarily complete their prescribed treatment. And to start off with, just about 1% are actually identified with delays and disabilities when the number is much higher. Next slide. And so the 3 innovations that were tested included group-based parenting support, including mental well-being support for these young mothers in Kenya, which was associated with a reduction in depressive symptoms, as well as an improvement in interpersonal relationships with their significant others, integrating screening and counseling on perinatal mental health as part of antenatal and postnatal care in Mozambique, showing that this could be task shifted to primary health care providers, not necessarily just the specialists, but also community-based rehabilitation for these youngest children, which included parenting support for parents of children with these special needs, improving referrals, as well as providing specialist outreach, which resulted in a massive increase in the number of children being identified and parents feeling their children were doing better. Next slide. And these are just some images of this work in action. This shows a nurse, a maternal child health nurse in Mozambique, counseling on maternal mental health to a caregiver, as well as 2 screenshots of the tools being used. The next slide. in Mozambique showing our partner a demo with two parallel bars that they have built with very locally available materials to support children who may have developmental delays and disabilities to help them to walk. And in the right, I know that we're running out of time, but I do wish to showcase this really innovative model that this person on the right is holding stuffed pants, where you essentially put, a set of trousers, put rags and cotton inside them and use that to support, for example, children with cerebral palsy to help them to sit upright when otherwise it's difficult for them to do so, and using materials that are available in the community. Next slide. And at the very end, right now, we are in the process, or just have recently concluded, a process of systematic human-centered design, where we realized that we were hearing that not all caregivers mentioned being counseled, that we were hearing that there were some issues with the quality of the counseling, that some touch points were offering better opportunities for counseling, but others were not offering those opportunities. And so we engaged service providers, managers, caregivers in a process of iterative human-centered design to identify specific touch points, specific improvements that could enhance both the quality of services as well as absorption of key messages by caregivers. Next slide. And my last slide. So coming right from the beginning, like I'm trying to just sort of like summarize everything. The beginning, we started off with this model that went, expanded, make it universal, all touch points, same messages, whatever could be done to promote early childhood development, to now identifying specific touch points where we felt that we could get best bang for a buck. This included counseling during antenatal care, in maternity wards, where oftentimes men are present when they come to pick up their significant others or birth companions, who can be sisters-in-law or mothers-in-law or friends who come with caregivers counseling there. Task shifting some of the counseling from the consultation room to the waiting area, whereas we talked earlier, caregivers spend a lot of time waiting to receive services, and having community health workers and other personnel provide some of that initial counseling. The play sessions, which take place in the waiting areas, we decided that they needed to promote more complex early learning activities, so not just rattles and shakers and those sorts of more simpler toys, but also complex activities that would cater to older children. And in Kenya, we heard loud and clear from service providers that they loved the idea of using the Ministry of Health standard Mother and Child Handbook, Mother and Child Health Handbook, which is something that is universally used and which includes developmental monitoring and counseling content as the primary vehicle for providing these services. So I know that's a lot of ground to cover, but I'm hoping that we will learn more during our panel discussion. And as always, we're open to further discussion, questions, and inquiries. Over to you.
Thanks, Debjit. I think I'm going to pick it up from here after you've told this amazing story of all the work over the last 10 plus years across the world, and particularly in sub-Saharan Africa. It's really, really an honor actually to hear the whole story from beginning to where it is today. And as you've said, it's not over, it continues, it grows in another way. And we're fortunate today to have some champions among us who have been on this journey with you and with all of us, and who are ready to continue this work going forward. So I'm going to ask our panelists to turn their cameras on. I'll invite Marina Karagianis from Mozambique. If you could turn your camera on. Janet Karimi and Ken Orenjo from Kenya, if you could turn your cameras on. And Mesrat Zelalem from Ethiopia. If you wouldn't mind turning your cameras on, then we all see each other and know we are ready to go. Super. And Ken, when you're ready, you can turn your camera on also. Oh, I see you. There you go. All right. So I have a series of questions. We're really interested in learning from you, understanding from each of your experiences on this journey of promoting early childhood development in health systems. And so maybe I will start with Marina. Now, before I do that, I just want to let the audience know that Marina will be speaking in Portuguese. So if you would like interpretation in Portuguese, please remember to look for that globe on the bottom of your screen and switch to Portuguese so you hear Marina's response. sorry, switch to English so you hear Portuguese spoken in English for you. So Marina, question for you. Debjit talked about a whole journey that's taken place over several years. And I think we'd all love to hear from you. What do you think has changed in Mozambique? What have the changes been that you have seen in terms of promoting early childhood development in primary healthcare?
Bom, queria antes de mais cumprimentar a todos. Muito obrigada, Sheila, muito obrigada pela questão. Eu quero agradecer o convite que foi feito ao Ministério da Saúde para participar deste painel.
Sent to the Ministry of Health to be part of this panel. I'd like to greet my panel colleagues. Well, now, what changed in Mozambique? Mainly the perspective we had regarding the role of the healthcare sector in this challenge of ECD. Our perception changed, but also the idea and learning that we had, which is very important, that at the Ministry of Health, we should be coordinated between different departments and ministry programs. We learned that it's necessary to have a complementarity in the approach. We are on the same platform. We have all the programs that address the attention to the mother and the child, and the child health program, mental health, rehabilitation for physical disabilities. So we are working in an integrated way, and we have also learned that it's very important to be aligned with our implementation partners, because if we implement in an isolated way, we won't reach our goals. Other lessons, other takeaways, it was the appreciation that it is very important to have the role of the central level, the provincial level, the district level, the health facility level, and the community's role. So over this period, what we have learned, what we have realized is that it is very important if we want to integrate and have the approach of ECD in integrated way, we need to look at our guidelines. So we started, as it was said in the first presentation. I saw the first presentation and said, oh, yes, this is what Mozambique did. We did exactly that with the support of PATH and other partners. So we strengthened what we had, started integrating in our guidelines, everything about child at risk, mother and child, for mother breastfeeding. So we have been incorporating all the aspects of ECD aspects. So how did we do that over these 5 or 10 years in the implementation? Mozambique conducted a strategic implementation in a regionally or subnationally. So we are not in all the country, but we had some implementation in northern Mozambique, in Nampula, in some districts, the central region in Zambezi, and also in the south region in Maputo province. So this implementation with the support of USAID, PATH, and other partners that support this implementation program, we have so many takeaways, many lessons. It's from these lessons that we are now going ahead for scale up. So effectively, this is what has changed. This is the approach that we had in an integrated way, in a coordinated way, in an aligned way, incorporating in what we have already been doing.
Wonderful. Thank you, Marina. I think, you started, and I think we'll hear this from other colleagues on the panel today, this change in the perspective of the health sector and this realization that the health sector is a pivotal role and has a very important role to play. But you also went into some of the other changes that have happened, and we'll come back to some of those again in a little while to see what were those changes that really helped move things along. Why don't we come to Kenya? Ken, what would you like to say in terms of what has prompted this change in primary healthcare?
Yeah, thank you. Thank you very much. I think I'm audible. My name is Ken Orenjo, just as been mentioned. And I think it is clear that there's been a lot of change in the last decade. And some of the key things that have changed, of course, is we've had an increase in the global advocacy and research evidence. Just like you've had Debjit mentioned, the research that they did, that of course made it possible for us to be able to make some changes in our tools. There's been several landmark publications that of course support now aspects of caregiving, of course, both at household level and also enhancing play at health facility level where we get this particular kind of services for the children. We have certain global frameworks that have come in place, that like the Nurturing Care framework by WHO, UNICEF, and the World Bank. I think there's an aspect of course, enhancing and telling people to be able to conform to such frameworks so that they're able to scale up the good things that have already happened. There's also the integration of ECD services in our routine health services. Just from the survey that was done, we're able to integrate aspects of immunization and also, of course, stimulation of children with this particular aspect within the mother-child booklet. And so we're able to, of course, enhance some of these particular services that were not embedded in ECD earlier on. The aspect also of technological and digital innovations that have happened. There's the digitization of certain tools that will support scale-up of ECD. Like in Kenya, we have the community health services data system that has been digitized. And some of the aspects that are now there are things to be able to look at issues of developmental milestones of children. So these are things that have come as an aspect of innovations and has really changed the landscape on how now we view issues to do with early childhood development. There's also aspects of policy shift because, like, for example, for Siaya, we have a nurturing care for early childhood development strategy that we've been reviewing and utilizing to be able to enhance the aspect of people scaling up ECD. Thank you.
Thanks, Ken. You touched on a number of things there from the global and the local. We'll come back to those. Mesut, maybe you can share some perspectives from Ethiopia. What has changed?
Thank you very much, Sheila, and good afternoon, good evening, colleagues. And let me first convey my sincere appreciation to the invitees for inviting us, the African Center for Early Childhood Development, for this very crucial global panel. Thank you very much once again on behalf of our center. Let me just start up on the factors that really brought up a change in the arena of primary health care for the, leveraging the ECD activities. One is a global factor, as colleagues has already mentioned. The global factor is the benchmark. I can say the Lancet series, which has been launched. That was really the foundation to just leverage, the ECD activity. The other thing is the WHO effort is really commendable, and the UN, including UNICEF and other, including World Bank, the nurturing care framework, which is a landscape, the roadmap for the global community to implement and endorse based on the context on implementation of ECD. That's really the remarkable global benchmark that we have. And when we come back to the local factors which contributed for the change are, the national vision in general in the country, and the political initiative and commitment toward this prosperous and peaceful nation. this is really, a grounding, a key element, I can say, at the national level. And also the leadership commitment at the highest level really give a buy-in for ECD. I can really show up the leadership at the city administration, Addis Ababa city administration, how ECD is evolved in a very short period of time. You can really imagine how the leadership, Her Excellency the Mayor, is taking up at the highest level with a huge commitment that's really spread to the country. And also the finding out champions, I can really table myself as a champion. In my former leadership at the Ministry of Health as a remedies director, I'm the one leading, coordinating my team to liaise with other sectors, education, women and social affairs, to come up with this policy framework that's really endorsed. And we have a good technical working group established, and we have champions like Tina. From the leadership, I can really mark on highest leadership from Her Excellency the Mayor Adanich. She is really one of the iconic leader taking up ECD at the highest scale. And the other thing is the engagement of the donors and the partners. Like, I have to really commend PAS, Big Win, Bernard and Valley Foundation, WHO, UNICEF, African, the African Network for Early Childhood, and there are lots of actors who are really assisting the country. I think this is really a good driving factors, just to mention a few. Over to you, Sheila. Thank you.
Thank you, Ms. Red. So maybe, Janet, maybe we can come to you and see if there's any other factors you want to shed light on from Kenya or more broadly that have prompted this change. You're on mute.
Sorry. All right, thank you very much. I'm Dr. Janet from Kenya, heading newborn and child health. So I think a lot has been said by those who've spoken before me, but majorly I think just having the framework, the nurturing care framework for ECD is quite the guide, because it gives tools on how to really develop nationwide programs. And the partnerships, like has been mentioned, I mean, it's really commendable on a global scale, how UNICEF, WHO, the World Bank, and various donors or funders have been able to come forth to give both technical and financial support to countries to actually implement ECD initiatives. And I think one key factor has been the advocacy at a global level, even now reaching the governments, because there's been quite a push to now take this to the governments, no longer have partners drive, but actually partners support the government drive the agenda, and that's the only way to scale up nationally. So in Kenya, I would say this has been a great effort in helping us now revise our ECD strategy policy, which is now integrated, and it has also brought a lot of multi-sectoral coordination, working with the Ministry of Education and Ministry of Labor and Social Protection to come up with an integrated ECD policy with action plan, which then the subnational level can adapt or replicate to suit their subnational county needs. So that has been quite a driving factor for us.
Thanks, Janet. Maybe I can just summarize here a few things that have come out from the four of you. I think there is this aspect of an alignment at different levels with global actors as well as national actors, engagement of different types of stakeholders, working together for a common goal, and supporting the government to take this forward, looking for different opportunities in the country to try out different opportunities, test them, generate some momentum, but also create alignment and sustainability through the updating of different policies or guidelines. And I think it was Mester, as you were speaking, you were reminding me of the phrase in the nurturing care framework when we talk about it's a whole of society and a whole of government approach. And I think all of you in one way or another have touched on that it really is us all walking together and supporting each other that has really make this shift possible. A document is just a document until we turn it into action. And with the support of all of you and many, many others, we've been able to take that document and actually put rubber to the metal and put our foots on the ground and actually make something happen. So I'm curious to hear then, what have been some of the major successes? And I think, Ken, you started to touch a little bit on some of that in your remarks, but maybe we can hear from others on their successes in introducing and scaling up services that promote early childhood development through primary health care. And maybe this time I will start with Mesret from Ethiopia.
Thank you very much, Sheila, once again. It's really impressive. I think there are success stories that can be really shown up here. The national success, I can say, the endorsement of the national multi-sectorial policy framework, which is a signed one. That is, the landscape that is implemented. And also, that has been used as a kind of, I can say, a Bible or something for us to navigate to a good implementation. So the other thing is integration of early childhood development and a touch point, in a 5 touch point in a health system. So that's really very important because the already existing health system really given us a chance to easily integrate ECD to the system. So I can really show up in Addis, all health centers, and also 12 public hospitals has integrated already early childhood development to the health system in a 5 touch point in a antenatal, delivery, postnatal immunization, nutrition, JMP, and also under 5 clinic. I think this is really a remarkable success I would like to really table. The other thing is in Addis, 5,000 parental coaches has been trained, the training curriculum has been, endorsed, prepared, endorsed. 5,000 parental coach has been trained. They're providing house to house, the parental coach service. This is really a remarkable success story, which is also shown up, in this city administration that's led by the health sector. The other thing is, we are the, presence of the establishment of our center, the African Center for Early Childhood Development. It is a government entity, which is, established in the year 2023 as a Center of Excellence, which is renamed by the new regulation this year in 2024 as African Center for Early Childhood Development. This is established with 4 core functions: knowledge hub, research innovation, capacity building, quality assurance and standardization. This is really a great departure, which we have benchmarked this, and we have started joint planning implementation in 5 regions. We have so far finalized a baseline assessment for 2 regions, Oromia and Trade-off. Now we are going to navigate to have a baseline assessment for 3 regions. So now we are scaling up to 5 regions, taking Addis as a benchmark. So that's really the success story that I would like to show up. I think this is it. Thank you.
Thank you, Mesret. So from policy to services to institutions that can really take everything forward. Why don't we come to Mozambique? Marina, what are some of the successes you would like to share?
Testing the English channel. Well, I would like to start by mentioning the achievements. This year, our essential package was approved. We had a package that would organize our system in 4 levels. Currently, we have revised that. The essential package has 3 levels of attention: primary, secondary, and tertiary. And hopefully, this is a very good achievement for us because we are looking at ECD. We are looking at ECD thoroughly now. And this is going to allow us that the ECD agenda can become a priority, which was not the case before. And as time goes by, we have also included the content for ECD in our training curriculum. Currently, many training curriculums for nurses, for the rehabilitation technician, nutritionists, also include in the pre-service contents for ECD. We have also have our action plan for ECD. We already have many manuals for the promotion of activities for ECD in all the entry doors for the health of the child and the mother.
Monitoria de desenvolvimento.
We have also adapted the manual for monitoring of development. It's a manual that we have adapted for Mozambique, which is an experience of Malawi. We also have a lot of material produced, material that is available for the health facilities and for the community. And also all this work that was done at the level of the health facility and the level of the community is making sure that we can start understanding in the community the fact that we have so many cases that before you couldn't identify them. We have a case in Monapo, which is a district in Nampula province, where we were working for ECD. We could see that the district had many cases of hydrocephaly all of a sudden. So why so many cases of learning development in children? So all these are success stories that are allowing us to understand what situations do we have. It is also allowing us to have solutions for these cases. And the question that the ministry asks is that only happening in Monapo district? Don't we have the same situation in other places? So now, the fact that the Mozambique did not implement that at the national scale, which is the biggest concern now, but in the places where we are implementing, we can now see results. We are now clear about what could be happening in the country and how can we support. And another good milestone we had is the introduction in the admission. The children who are admitted for malnutrition that are in the wards, when they get better, the children also get stimulation exercises. We teach the parents to show them some empathy. And last but not the least, during our demographic survey in 2022, we had for the first time included some indicators. We are going to improve, but we want to keep the good work so that with time, we can have more indicators showing us the situation when it comes to ECD. Thank you so much for your kind attention.
Thank you, Marina. So many different experiences there, different existing services being utilized in different ways, and learnings coming from Monapo, which hopefully will help you think through how to take all of that learning and support other areas of the country. Let's turn to Kenya. Janet, successes.
All right, so for us, as I'd mentioned before, the integrated ECD policy, which is to be launched soon, I think will greatly help the scale up of ECD to all the counties in Kenya. We look forward to that. And alongside it, we've also developed the social behavior change communication strategy. So this has key messages targeting different audiences, including the caregivers and the healthcare workers. So these are ready and have already started being used in creating awareness on ECD, on social media, and even print and visual media. And this was used in the last campaign we had with the Kenya ECD network. So that's already a success for us. I think my colleague, Dr. Ken, mentioned the MCH handbook, Mother-Child Handbook, which has messages integrated for ECD for monitoring the developmental milestones and talking through what ECD activities one can engage their child in at different levels, from all the way actually from pregnancy. And we've also had prioritization of preconception care, which is also a key intervention for ECD, where if one can, plan to get pregnant, then they can take even more precaution in terms of nutrition. So that has also been prioritized in Kenya. Just like Mozambique, we had the introduction of the ECD index in the last demographic health survey, and that will be a continuous process, and we look into collecting other indicators even through other mechanisms, for example, the mix survey, but also in our own tools, we are looking towards revision of tools so that we can collect some ECD indicators, like is in the case of Siaya County, where they have added some data elements. For example, if the parent was cancelled for stimulating the child, or if developmental milestones were actually checked. So those are not currently there, but with those lessons learned from Siaya, we plan to update our documents to capture that. We've also adapted the care for child development for Kenya specifically for training of our community health workers, who we now call the community health promoters. Actually, it's not only for community health promoters, we called it's a curriculum for community workers. So whether community health workers, whether the child or children's officers, or whether the early learning officers at community level, it will be used by all three arms to reach the community. So for the health module, we'll see how we can integrate that into an already existing curriculum for maternal newborn care. So that is our next area. And again, due to partner support, we already have that support to integrate the ECD curriculum into an already existing curriculum so that we don't have fatigue from the community health promoters having to learn about community maternal newborn care, which carries health and nutrition. So we'll just see how to incorporate now the other aspects of safety, security, opportunities for early learning, and responsive caregiving. But we'll still keep the entire curriculum, which is for use by other community workers. So with that also, we are looking into integration of developmental milestone monitoring to other modules like the integrated maternal newborn child infant training, IMCI, so that at least developmental milestones are taken care of in that aspect. So those, I would say, have been our major successes at a national level for Kenya.
Thanks, Janet. Before I summarize, maybe Ken, you'd like to share from a perspective of at the county level, at a subnational level, any successes you'd like to add?
Thank you, Sheila. I think Dr. Janet has brought them out clearly. I think some of the things that we've picked as successes, especially for Siaya, is the successful models and frameworks that we are working under. Like, for example, the nurturing care framework that you're working in, the multi-sectoral model that you're working in as a county that brings up the aspect of leadership and how to be able to scale up governance of ECD services. And of course, putting that into and joining that to the maternal health platform and services like nursing, routine immunization, and also antenatal care. Janet has broadly talked about the scalable training models, which also applying in Siaya after the national has prepared the particular modules. Then we do that cascade through the CHFTs when teaching the healthcare workers at service delivery point, and goes to the community health promoters who again eventually will also pass the same training to the caregivers. There's been also a lot of community engagements. And there are many, these particular programs have leveraged on local community health workers to provide, of course, culturally sensitive and, of course, context-specific guidance, and also on responsive caregiving. And this has really brought in the aspect of community embracing the aspect of early childhood development. Maybe the other bit that I can mention is on the issue of evidence of impact. Of course, you're already seeing some particular good results, reduced developmental delays, because most of these particular children are now identified at household level and they're able to be supported. And also, of course, improved caregiver-child interactions. And this can be seen within the programming areas, especially when they bring their children to the health facility and there's introduction of the play as an aspect of supporting these children while they are at the facility and waiting for the service. I think these are some of the things that, of course, we have already seen as aspects of success at our level. Thank you, Sheila.
Thanks, Ken. I think what's so interesting listening to the four of you is that the successes are similar and they're also different. And they are so contextual to each of the three countries represented here today. There was a little bit around policy and creating that enabling policy environment. Services, a whole wide variety of services and cadres that you're working with in facilities and communities and beyond. But nuanced, very nuanced in each of the contexts. Data, generating data at different levels, understanding what the needs are, and then adjusting your programming accordingly. And then even things, Janet, you mentioned the social behavior change, so looking for different ways to reach different audiences and sensitize different audiences. So I think it shows that, there isn't a straight path to this. And, sometimes the questions come up about where do I start? What do I need to do? But it's a combination of multiple things, and it's about seizing the opportunities as they come. So as curricula is being developed, or as you're refining your services or developing policies, using those opportunities to look at it through that lens of nurturing care and look at it as what is it that the children in my society need. All of you spoke about different learnings at a deeper level, whether that's in a district or in a region or in a county, and how that's now informing the way forward. So we hope that that will continue to expand, and that in the future you'll talk about multiple regions in the country or multiple parts of the world joining forces with you. So as we conclude, we've been talking about so many positive things, but there's always challenges on this journey. And I know you probably have many, many challenges you could speak about, but if I could ask you maybe to focus in on one challenge that has perhaps, maybe it's been resolved now, or maybe it's an ongoing challenge, or maybe it's a challenge you think others might be facing, and you're seeking perhaps advice in this conversation that will follow on how others might have addressed this challenge. So maybe we can start with Kenya this time. Ken, would you like to start?
Thank you, Sheila. I think the main challenge that I think we are facing, and also anticipating during this particular scale-up, number one is the resource limitations in low and mid-income countries to be able to sustain these ECD programs. I can give you an example of as SIA had a good, a best practice in the model they're using. We were trying to scale this up in the Lake Region economy that has 14 other counties. I think it's becoming difficult because of the aspects of resource limitation, because there should be that particular committee that is put in. And allow me just to mention again another one, which is basically cultural and contextual adaptations. There's difficulty adapting the global ECD strategies to align them, of course, with the local cultural practices and also languages. I think that's something that has really made it a little challenge to be able to speed the scale up of ECD services at community level. Thank you, Sheila.
Thanks, Ken. You've piqued my interest, but I'm not allowed to probe further yet at this time. Maybe we'll come back to it. Janet, over to you.
Okay, I think he's mentioned the big one, which is financing. But another aspect is just being able to convey the message of what ECD is to different stakeholders. I know in Kenya, there was an ECD conference where all the sectors were invited. So we had the leaders from the health sector, education sector, social protection sector. But traditionally, ECD has been seen as something in the education sector. So the advocacy required for these other sectors, and I speak for health particularly, to see that they actually have such a great role to play in that period between pregnancy and 3 years, even before this child steps into school, is really a big gap that we need to fill. Of course, it does require resource commitment, but also that energy to bring all stakeholders on board. And with that, also the I would say it's a challenge, but it is not an unsurmountable challenge to work in the multi-sectoral coordination so that if there are already existing mechanisms, for example, in Kenya, we have the Children Advisory Committee in each county or district, which is concerned with all matters to do with children. So for us in Kenya, we work together and say, rather than develop another technical working group for ECD, why don't we just work through this Children Advisory Council, which is already existing, which already has all the stakeholders from all the sectors. So it also requires now for each sector to be collaborative and see what is most cost effective, leveraging the resources that each of the sectors has.
Thanks, Janet. As you say, it's working together. It comes with ups and downs, right? And finding those mechanisms of how to do that together. But it starts with us all having a common understanding. So making sure we all see ourselves as part of this. Mesrat, can I come to you?
Thank you, Sheila. I do share what colleagues from Kenya has mentioned. I would like to also repeat that from Ethiopian context. As you know, Ethiopia is a vast country with multiple layers of expectations are there, and we have a policy landscape that has to be implemented end to end. And there are different contexts. For example, urban context, agrarian and pastoralist context. There are different values and cultures. So still resources limited. In terms of financial, commitment, it needs additional resource and innovative modality to reach to the end users at the the remote area. We should be in a position to shield the most vulnerable crops. So this is very critical. The other resource might be how we can. It will be like, I'm not just tabling as a challenge, but as an opportunity for all of us here together to come up with solutions. Like we need to have, as African continent, good to have the database on the trained manpower to have an exchange. That is also lacking from my end. This is my thought. The second, perhaps out of the resource arena, local evidence. That's why we are doing on the baseline assessment for different regions, because we didn't have local evidence, and also we need to also deep dive to the local culture, context, and indigenous knowledge that will definitely leverage the ACD activities, parenting, and the like, so that it's good to have a local evidence. I would say this is also another area for all of us to just tap it together. Thank you. Over to you.
Thanks, Mesrat. I liked that idea of thinking about how can we facilitate maybe a community of practice opportunities for people that are implementing to be in contact with each other in different parts of the country. Marina, we started with Mozambique, so we're going to come back and end this session with Mozambique. Any challenges you would like to share?
Muito bem, muito obrigada. Bom, se eu tiver que falar sobre os desafios que nós enfrentamos.
Thank you.
Não gosto muito de falar de desafios.
I don't like to talk about financial challenges, but they're important. We did have a lot of challenges, and this was a concern. But I always try to bring examples that we had, how we have solved in the past. The strategy of use of key message and disseminating in the radios and in the community radios was very important. Messages about stimulation, the importance of having a conversation with the children and the baby. We shared so many messages in the community radios that currently, even if you don't pay the radio to disseminate that information, they are still sharing those messages for free. A week before, we've heard one of the leaders of the country saying that we need to talk to the babies on our bellies. So that was a huge and good experience for us. It means that we need to keep working with dissemination. Another positive experience was in Nampula. with very few financial resources. We managed to implement ECD activities in Monapo, and the government used all the strategy that we have, and they started to work with ECD, showing that it's possible to do things in an integrated manner. Now, challenges. We don't have a strategy, a guiding document for the sector in the area of ECD. And to solve that, I would like to say that we are already working on that. So we already have documents, policies for ECD integration. So currently what we need to do is working at the national area. We need to have resources. We have lack of resources, but we are going to work to have the cascade training and start implementing up to the health facility, up to the community. We have so many norms and rules. We just need a guiding document that is going to make sure that the partners and us can be aligned. Another challenge that we have has to do with intersectional coordination that is starting in Mozambique. I've heard other panelists from other provinces, from other countries, saying that they're already aligned. So we need to have this intersectorial coordination. We need to improve it. And another future development is that to respond to lack of strategy. Currently, the ministry is currently identifying all the interventions that are being implemented both by the private sector as well as by the partners at the level of the health facility and the community. So what we need to do is bringing the lessons learned and also identify the opportunities that were lost and how can we improve. And after that, we will be able to set this guiding document. So these are the main challenges for the next time for ECD.
I liked that example of radio. It made me think, you know, there's so many different entry points that we could be exploring, and given that the resources are we need to get creative and think about what goes in different platforms. So what do we do through radio or other forms of media? What do we do through our services? What happens in the communities? What happens in curricula? You know, what are the different platforms that we are using, and how do we use them in the most efficient manner? So that we can all continue moving forward, right? We don't want to, it was a recurring theme I heard across the three countries, spoke about resources in one way or another. But hopefully through the successes that you've had, the groundwork has been laid, right? The infrastructure is there, the enabling environment is there. It's about how we seize that and move forward together. So thank you to our panelists today for sharing all of these experiences. Really helpful, really insightful to hear the different, but also similar sometimes experiences across the three countries of Kenya, Mozambique, and Ethiopia. So with that, I want to thank our panelists for being with us today, and I'm going to hand back to, I think, Lana at PATH.
Thank you very much.
Sheila?
Yes, thank you, Karen, for projecting the slide. Maybe you can go to the next. Thank you so much. So I know we are running out of time, and so I'll be very short. I just wanted to ask people who are still with us, if you can put in the chat whether you have already interacted with PATH ECD Knowledge Hub. Just say yes in the chat, because we are curious how many of you already know this resource. If you don't know or you just heard about it, this is a key summary, and we're also putting the link to it in the chat for those who have not accessed it yet. So this is really like a repository, I would say. It shows what we've been doing for the last 10 years, not just in the primary healthcare, but also in some other platforms with social action in Mozambique, for example, with community radios, community videos, and other types of platforms. And several of you had questions about specific touch points. And so if you go to the Knowledge Hub, you will see it is organized by touch points. It looks at antenatal care, maternity services, postnatal care, child services, community health platform. so that it has examples of tools, training materials, job aids for each of those key services. And you also see how they evolved over time. Talking to what Devjit said, we started with very bulky tools and gradually they became leaner and more aligned with government, what government is trying to promote and government tools. You will also see quite a few examples of tools that were not designed by PAS, but to which PAS and other partners such as WHO and UNICEF contributed, such as policy, strategies, guidelines, home record books, and HMIS registers. And I think they're quite interesting to see because it allows you to kind of compare and contrast and see what could nurturing care look like in a national strategy or national policy, and then see how it is actually being rolled out in implementation. Like, for example, what indicators are being collected in HMIS registers? Are they only on developmental delays, or are they also about counseling? So I really recommend to go on to browse through it and see what you find. The materials are in English, Portuguese, and Amharic, and some of them are in more than one language. There is a feedback function which you can use and request or ask if some of the materials are in another language, then we will share it with you. And we are still growing the hub. There are additional training videos coming up. We already have videos on Playbox, on community, on well baby clinic interventions, on ANC, on maternity wards. But we are developing more videos, especially from Kenya, where we are trying to show how a home record, a mother-child health handbook can be used, for example, which already has milestones and counseling content, how it can be used by routine healthcare providers in community and facility to counsel on child development. And also because we are supporting some childcare work, exciting work in Ghana on childcare, we will try to host that content as well as soon as it's available. So please look at it, learn with us. There are about 30 briefs summarizing formative assessments that we've done of different interventions. And I think they're quite interesting. They're not these bulky kind of RCTs, but they're really nimble, small formative assessments, which kind of indicate what works and what doesn't. And we really invite you to kind of read them critically, assess them, react to them, and take this work further in the coming years. Thank you so much.
Thank you so much, Lana, for a quick walkthrough of the Knowledge Hub, and please feel free to continue interacting with it and providing any feedback, if any. And so I think we're going to take the next couple of minutes just to go to the Q&A. And I know there are quite a number of questions that have been asked on the Q&A session. Also from the chat. Some of them we have tried to respond to them, but there are a couple of other questions that maybe we can open here for discussion. And so I would want to request Devjit if you can take a couple of questions. And one of them is the question on the toys in terms of managing the security of toys at waiting areas, as some caregivers may take them away with them after session. I know we've responded on the chat, but maybe you can just come and elaborate more a bit on that. And then there was also the other question on the from Victoria in what intervention approaches were used for contextualization, localization of integrated ECD within the healthcare. And then there is also a question on from Kazumi, and mentioning that thanking you for the precise and useful presentation. While it is relevant and essential to integrate ECD counseling as part of ANC, healthcare providers are often overwhelmed by or not necessarily capacitated for many checklists of ANC contents. Have you faced implementation challenges? How have you overcome them to ensure the quality? So I will pause at that point and open it up for Devjit to answer, and then we will carry on from there. Thank you.
Thanks. And I'm cognizant that we only have, we are trying to end in the next 5 minutes, but I hope a few of you can stay on for a couple of more minutes. So I'll try to be concise. The first one is around the toys and the play materials. And one thing which you'll notice is that we emphasize the use of the term play materials or playthings. These are not store-bought toys. These are not toys we bought in the supermarket. They're made with pretty much what would be considered trash. So we're talking like yogurt cups, we're talking cardboard, string, bottle caps, anything that would normally be thrown away. And those can be those can be used to create really beautiful, stimulating toys. And so the idea is that even if children do take the toys with them because they take a fancy to a particular toy, get upset if someone tries to take the toy away from them, it won't be a huge loss because someone at the health facility can create a replacement. We also have guidance on sort of a logbook or a registry of different toys for children of different ages and would stimulate different domains of development. And we hope and expect that the facilitators of these play sessions can ensure that the box of play materials can be restocked from time to time. Caregivers are also encouraged to bring in some play materials with them. Once again, not going to a shop, but using materials that they would normally throw away and put together to make a play material which can be shared with other children or their child can play with. And as Melanie has mentioned, in Mozambique, we actually experimented with working with local primary schools. Getting kids in these schools to develop some of these play materials is a very nice way for them to feel more engaged with the community and for them to do something that could contribute to the greater good. So in a summary, we're not using supermarket toys, and so it's not the end of the world if some of these play materials walk away. They can very easily be replenished. Regarding contextualization, so contextualization has taken many different forms. Obviously, formative assessments are very important. We make sure that the messages, simple things like how the characters look in the counseling cards, whether they're culturally relevant, whether their hair or the dress that they're wearing is relevant, to more technical contextualization around the relevance, the cultural relevance, and the technical relevance of the messages done through formative assessments. In addition, we have done human-centered design in the last couple of years, which is much more intensive. It's much more on your feet, kind of dynamically evolving contextualization on the basis of feedback that's received in an iterative fashion from key stakeholders. And the human-centered design has really helped not just contextualize materials in the way that I mentioned, but also helped with understanding what touch points can be used to maximize both quality of delivery of services as well as uptake of desired behaviors and practices by caregivers. And the last question about overwhelming service providers, I mean, that is such a valid question, such an important one. I know there is this temptation to just keep adding new technical areas to healthcare workers, knowing that they are so busy and so overwhelmed. And so we have tried to be very conscious, as if you remember from my presentation, where we started kind of, big and then started really condensing the materials down into initially 2 posters and now to saying, well, let's use what already exists to the greatest extent possible, which is in Kenya, the Mother and Child Health Handbook, which every caregiver has with them once they become pregnant. So we have been very conscious about not overwhelming health service providers. We realize that health service providers love this work, but they also do not like extra data. And so we've been very intentional about not adding a barrage of new indicators. So it's not like there's 20 new indicators. The one indicator that we have facilitated through advocacy for inclusion in the health information systems is literally how many children have a suspected developmental delay. So for the most part, it's a very simple, straightforward indicator and not multiple indicators, which might add extra work for health service providers. Over to you, Dickens, and thanks for the questions.
Yeah, thank you. Thank you so much, Debjit. I know we are running out of time, but there is a couple of 2 more questions. And this might be open even to our very able panelists. And feel free to chime in if you can be able to answer. And there is one question from Veronica and says, how can we strengthen efforts to implement policies that integrate early childhood development initiatives in health facility waiting areas, ensuring they are effective, ensuring they effectively support pregnant women and promote inclusivity? What strategies could be prioritized to enhance outreach and impact? And maybe just to humbly, maybe if I can request Director Ken, if you can speak to this, or Janet, before we can maybe hear also maybe from Mozambique shortly. Thank you.
Thanks, Dickens. I want to believe one of the things that should be done in strengthening policy is of course coming together in a partnership kind of way, so that the community also becomes part of what, of course, informs the policy that we need to have in place. Because the main thing has been, yes, policies developed, disseminated, but now the biggest aspect is normally the part of course, implementing this particular policy. So if it is all inclusive during the development and coming up with this particular policy, so that then they can be reflective of what is locally done and local solutions to be able to then move along with the policy implementation. Thank you. Janet can add on.
And actually, what I'm sharing is an example learned from CIA, that on the implementing opportunities for early learning at health facilities is just to work with the healthcare workers who are already there and the community health promoters. So, for example, in CIA, we have the community health promoters coming on the clinic days, and they give the messages to the caregivers and identify different age groups, and later put them in separate groups to give them messages on stimulation depending on the age group. And this is at the time where triage is happening, which, as was mentioned before, that takes quite some time. So like a 30-minute session is enough to communicate, but the message is still strengthened by having the community health workers still follow them up during household visits. And in the case of CIA, the community health workers were actually giving the messages in that local language, which I found to be very interesting. And it seemed very easy. So contextualizing, as has been said, is very important. On the level of translating policy to action, there is need for partnership, as Ken has said, but also between government and the subnational levels, so that even if policy is developed together with the subnational level, implementation is also jointly, and that it's important to have performance review to support where and learning, so that those who are progressing well can teach others, and that support can be given where progress is seemingly slow.
Thank you so much, Dr. Karimi and Ken, for those feedback. And maybe I just want to ask Dr. Meseret if you have any input in regards to that question, or Dr. Marina.
Sim, o que eu gostaria de
What
mencionar
I would like to mention is that, in fact, this approach of DPSC as intervention, they are conducted in many care rooms. So we are implementing interventions. What we need, we have seen. So what Mozambique did is to elaborate a manual. We already have these ECD promotion activities during the care at maternal and child health. So we think this is a good way. For example, at our antenatal care, we have basically what kind of interventions that help the ECD. So we go to birth, post-birth, and this is the integrated way that we see that makes it easier, the implementation of ECD. And also at the community level, our community health workers, our activists, they They have posts, supporting posts, they have guideline documents, they have some other material that help them to implement these activities. For us, the integration is the best way of implementation of ECD and including different norms and policies that we have reported on.
Yeah, thank you. Thank you so much, Dr. Marina. Dr. Meseret, do you have any contributions from Ethiopia experience?
Pardon? Thank you.
You may be muted if you're speaking.
ID can pardon me. Thank you.
Okay, thank you so much. I think there is, okay.
Heidi can pardon me. Thank you.
Okay, yeah, thank you. So there was a question in terms of how can we strengthen efforts to implement policies that integrate early childhood development initiative in health facility waiting areas, ensuring they effectively support pregnant women and promote inclusivity.
Okay, thank you very much. I think the Ethiopian experience is, the integration of ECD in a 5 touch point I was trying to address in my previous talk in antenatal care, because there is an existing structure and system for a remain set, so that given that already existing health system, it is possible to potentially unleash that one, starting from antenatal care and also delivery postnatal under 5 clinic using IMNSI. It's ECD is integrated, and ECD also integrated to the health extension workers package as a portion of child health, and also integrating into nutrition, because the nutrition needs stimulation, early learning, These are the touch points where ECD can be easily integrated and Ethiopia can be benchmarked. The other thing is the commitment really matters, There must be a buy-in from the leadership. There must be a strong coordination, because ECD is multi-sectoral activity. So the leadership and governance and strict coordination really matters. That's it. Over to you, Deacon.
Thank you very much, Dr. Meseret, for that feedback. And I think we have run out of time, and I just want to appreciate all the panelists and everyone. And I want to give it over to Debjit just to give us some final concluding message as we end the webinar. Thank you. Over to you, Debjit.
Thank you so much, Dickens. Thank you, panelists. Thank you, moderators, for an excellent session of learning, and for many of us, refreshing what we have been discussing over the last several months and years. This has been a wonderful journey. The journey has not ended. It's continuing. And we are so grateful for every one of you for being a part of this journey, for what you've done for the children in your respective communities and countries. And we want to again re-emphasize that that there's a ton of materials available on the Knowledge Hub, which Dr. Svetlana Driftal has just shared. I encourage you to look up those materials, see what's there, and understand how you could potentially to use them in your work in your country, and not just in the countries that have been discussed today, but countries in other parts of the world as well. As we feel this work is very relevant. The Nurturing Care Framework says how important it is for primary health care to expand its scope to include promotion of early childhood development and increasingly caregiver mental health, as for those of us who attended the launch of Caring for the Caregiver by UNICEF and WHO last month. So with that, I would like to once again thank everyone and wish you a good rest of the week. Happy holidays to folks that are taking time off. I do hope you can have a chance to refresh and rejuvenate. and continue the amazing work that you're doing to make this world a much better place for children, especially those who are vulnerable and need a little bit extra support. So thank you, everyone. Take care and goodbye.
Thank you all. Goodbye. Look forward.
Obrigada.
Thank you, everyone.
Goodbye.
Right?